to chew. You got no trouble biting your food while I'm here chopping pudding, so it won't be rude. I still miss the crunch of chips and the caramel goo. Guess that life ain't easy when your teeth won't do.
Hello and welcome everybody. Thank you so much for joining us today. My name is Elizabeth Daly and I am the Executive Director of the National Foundation of Swallowing Disorders. It's my pleasure to welcome you here today for this highly anticipated webinar with Dr. Reva Barewal. For those of you who may be unfamiliar with the NFOSD, our mission is to advance the treatment of swallowing disorders in our lifetime. And we do this by offering support, providing high-quality free education, promoting promising research, and raising awareness of the impact of swallowing disorders at a local, national, and global level. And while I have your attention here, I'd like to share a major advocacy initiative that the Foundation is planning in collaboration with the Think Foundation. We are hosting an externally led, patient-focused drug development meeting on dysphagia on June 10th. This is a powerful opportunity for people living with dysphagia to share the real-life impact with the FDA, researchers, and industry leaders, helping to drive meaningful change in dysphagia treatment and research at a time when it's needed more than ever. You can find more information by scanning this QR code, and you can also register for the upcoming meeting to participate, which will take place virtually in June. And as we continue to plan for this meeting, what we really need is to hear from people living with dysphagia and their loved ones. So if you are somebody with dysphagia, please scan this code right now and submit a comment about what it's like to live with a swallowing disorder. This QR code will open a comment form that lists about a dozen questions that you might consider answering. Your comments will be read aloud during the meeting with the FDA and published anonymously in a Voice of the Patient report. This is such an important opportunity to drive change for the future of dysphagia treatment. Also, we are just weeks away now from the National Dysphagia Awareness Month, and we are excited to be hosting an awareness campaign titled Blair in Jeopardy, where each day we will be sharing a dysphagia-related question on our Instagram page. One person who responds correctly and tags a friend will be randomly selected for a prize, either a cash prize or one provided by an industry sponsor. So make sure you don't miss this opportunity to learn more and win great prizes. So follow our Instagram page for that. And as a nonprofit organization, we rely on the generous financial support from our community and our industry supporters. We would like to recognize Bracco Diagnostics for their unrestricted educational grant that allows us to continue our TAD Talk series for free. And I would also like to take a moment to recognize our educational sponsors. Their long-term support has helped our webinar series grow since its inception almost 10 years ago. And a big thank you to those of you who are paying NFOSD members and who have made a donation upon registering for today's webinar. It's important to our mission for us to be able to offer high-quality education and to make this accessible to everyone, regardless of their financial situation. If you would like to contribute and you have the means, we invite you to scan this QR code or visit our website. Every dollar really does make a difference, and we thank you. And now, for those of you who have not previously joined our virtual events, please know that you will be muted throughout the presentation. We encourage you to ask questions at any point using the question box in your toolbar, and we have saved time at the end of the presentation to answer your questions. And for those of you interested in ASHA CEUs, please note that these are only available for the live broadcast today. Following the webinar, within the hour, you will receive a survey, and it's required that you complete this survey by May 15th in order to receive credit. For those who complete the survey but don't need or don't want ASHA CEUs, we will provide a certificate of participation. And I want to thank the Swallowing Training and Education Portal for being our ASHA CEU administrator for this. And now it's my pleasure to introduce Dr. Reva Barewal, who has volunteered to share her time and expertise today with our community. Dr. Barewal is a prosthodontist and a French-trained chef who has spent over 2 decades at the intersection of oral health, function, and joy of eating. With academic appointments in both dentistry and sleep medicine, she is redefining how medically tailored transitional foods can support rehab and nutrition. Reva is an innovator and a leader. She is the founder and CEO of Savory's Therapeutic Foods, creating transitional foods that empower both patients and providers. I want to thank Reva for accommodating my pop culture themed webinar title and my AI generated theme song that I'm not sure if you could hear when I was playing at the beginning, but give us just 1 second here and I will turn this over to Reva.
I'm so grateful to be here, and thank you, Elizabeth, so much for welcoming me and this topic. I think that I hope that this is going to be an interesting, not only academic presentation, but insightful towards your clinical practice. Thanks for the AI generated song. This is, I'm not a pop culture music lover, but here we are with Good for Chew. And I'm here to talk about a new way of looking at chewing through the lens of being a prosthodontist and melding that with, dysphagia care. So my hope is by the end of tonight, you'll look at oral mechanics and chewing differently than yesterday. I'm also going to challenge the value of specific food textures in adult therapy and stretch the possibilities from food for nutrition to food for therapy in dysphagia care. So I'm not going to spend too much time on this slide because Elizabeth did give you my background, but I just wanted to share something that maybe some of you, well, many of you probably don't know, is I was born in India and my jaw was crushed at birth. And so I had difficulty chewing from, the moment that, solid food was a part of my life. And so this is really what got me into prosthodontics and this desire to help people, because prosthodontics is more about oral reconstruction. It's more of a deep dive in dentistry. We treat patients with head and neck cancer. We treat patients that have multiple issues, complex medical conditions. And I just feel like it was the right fit for me because I really had this innate desire to heal and to help people. But I also, that exposure kind of led to this passion for food. When you're denied food or you have a change in your diet, you just kind of like either you go one way or you go the other. And I thankfully learned about culinary cuisine, went to Cordon Bleu and another French culinary school. And I am here to share that I think that what we have here is really unique. It is the compilation of this history and clinical practice of 30 years that I can share some insights with you that are relevant. But then it's also this like new passion I have for taking food culinary skill and turning it into food innovation and food that helps with a medical condition. And so that's how this all came about and why I'm here today and how the ideation started for Crispy Melts. So I am going to just start by saying, when I am sitting at my desk and I'm getting emails coming in, or I'm at the ASHA conference or other conferences, the number one thing that people come to me with is they say, my patients, they are complaining that their food tastes bland, they're tired of puree, they want to bite again. And, it's not like SLPs are saying, gee, that's really surprising. I don't even understand that. It's because we can easily put ourselves in their shoes and think, well, I wouldn't like that either. And it can be so strong for some patients that they're willing to sign a contract in which they understand their risks, but they're willing to take them just to eat their preferred foods. And I love the ideas that have come about to mold food and to make and to be creative in the kitchen to get more visual appeal, a very strong sense, a sensory stimuli that can engage someone and heighten their appreciation or anticipation of the food. It's also really cool because by molding, we're introducing food memory, which is a powerful signal for anticipation and food enjoyment. But we all know that it works, but it doesn't work, it doesn't resolve all the issues. And so today I'm going to share with you scientifically what is going on with the sensory signals to your brain when you turn on the switch to chew. and how that can affect our motor patterning and emotional response. So I'm going to try to give a little bit of background as to why patients are saying this. And hopefully by the end of today, I'm going to help you understand how we can switch that narrative, that internal narrative for a patient when they're on a modified diet, from I can't eat to I'm chewing again and I'm regaining my eating experience. So today, really what we're doing is rethinking the role of chewing as a functional and therapeutic target. So we're shifting the lens on chewing, not as a secondary process, but as an active functional target for dysphagia rehabilitation. So I'm going to invite you to rethink chewing not simply as a mechanical step in oral prep, but as a powerful neurosensory trigger and therapeutic opportunity. So we'll start with the foundational science and how chewing interfaces with the cortical and subcortical structures in our brain, and how sensory motor integration primes the swallow system or modulates the swallow system. And we'll explore what changes when chewing is compromised. Okay, so we're going to look at disease and dysfunction next, and we're going to focus on 4 key disruptors. Then I'm going to introduce this concept of functional textures and tribology, which is more from food science, but I think highly relevant. And, then we're going to get into how we can use functional textures in therapy. And I'll walk through a proposed framework for you for integrating these into therapy to support and share some emerging case data and application principles. So let's get back to chewing. So chewing and the eating process. Biting is not a repetitive functional cue, but chewing is, and it's the first repetitive functional cue in that eating process. And so we have to think, what is it doing? It's mechanically preparing the food for swallowing, but what I want to share is, as soon as that food enters your mouth, it activates oral mechanoreceptors, oral mucosa sensors, and muscle spindles, triggering this cortical activation in the brain in areas like the motor cortex, the somatosensory cortex, and insular cortex. Now, this primes the neuromuscular system and elevates attention, anticipation, and control. So at the same time that the chewing is also stimulating saliva production through activation of the facial and the glossopharyngeal nerves, preparing the bolus and the digestive tract. And this explains why even tasting or anticipating food can trigger salivation. So what's often overlooked is the link between chewing and your emotions, which is what I shared earlier. And so what we see is that this chewing in imaging studies shows the increased activation in the prefrontal cortex, the limbic structures, and the limbic structures during this chewing, which is really activating this reward and motivation and even mood regulation. So this can be really important, when you're trying to get someone motivated for therapy, and this idea of chewing and what it can do towards that pleasure area of the brain, and how that can potentially help you in progressing the patient. So this brain-driven approach to chewing and sensory integrated behavior I feel it's really exciting and setting the stage for everything that follows next in the swallow. So when we look really closely at what's happening here when we chew, the food first enters the mouth, and there's a network of cranial nerves responsible for oral sensation. And so the trigeminal, that is our that's basically dentistry, right? Like, it handles jaw movement and oral proprioception. Our focus is V2 and V3. And then, your facial nerve, cranial nerve 7, contributes to taste and facial muscle control, and 12 controls the fine tongue movements essential for, for that bolus formation and manipulation. But as the bolus moves posteriorly, you get more sensory input by cranial nerve 9 and 10. So basically what's happening here is these nerves are like they're dense sensory input, and they're going not only to the primary motor cortex and somatosensory cortex, and like I said, the prefrontal cortex for the emotional side of the equation, but they're also going into the brainstem. And so that impacts the nucleus tractus solitarius, and they're also the nucleus ambiguus, NA, which basically is that tightly regulated loop of sensory motor coordination that modulates that swallow readiness. So it's a brainstem event as well, and then you're getting those cortical and subcortical areas that from those ascending afferent pathways from the nerves. So you're getting, if we track it, right, it's coming through the cranial nerves, which project, if we're looking at swallowing and the influence of chewing and swallowing, we're going to look more closely at this interplay between that nerve stimulation and how it projects to the nucleus tractus solitarius, which is the sensory hub of the swallowing central pattern generator. And basically this NTS integrates the input and communicates with the NA, which is the motor output of the CPG. To influence the readiness for swallowing. So chewing isn't really a direct trigger of the pharyngeal swallow, but it can modulate the excitability and timing of the CPG. And so we don't have direct causal pathways that have been shown, but we can be suggestive here that this oral motor activity, including mastication, can influence the timing, the strength, and coordination of muscle of the swallow initiation. So, with that kind of like how chewing influences the cortical areas, but then also the brainstem, I can talk to you a little bit about some questions that always come up. Like I talk to dietitians, and they often say, like, what is going on with satiety? I have my patients on PEG tubes or even NG tubes, and they're saying they're still hungry, but they're receiving 100% of their calories and protein. And why is it that they don't have their satiety? And so, this is a complex issue, but what I know about chewing is that the chewing is, like I showed before, it's activating the insula and the orbitofrontal cortex. And those are the areas that help us experience taste and texture and anticipation and even the reward of eating. So when you have tube feeding, you're bypassing that loop, right? Like we lose that oral brain feedback circuit. And so when you lose that circuit, you get a disconnect, and you can have this lack of satiety, the feelings of hunger, disengagement from your food, and in some cases depression or social withdrawal. So really, if we're going to go into texture a little bit later, but if it's possible to even have brief oral activity during therapy, when you're tube feeding, it can give some sense of chewing or taste stimulation, and it can help reawaken these circuits and lead to satiety. So, we talked about the cranial nerve stimulation that's happening in the mouth with chewing. And so, the majority in the mouth of those inputs are coming from that trigeminal nerve and the V2, V3 maxillary mandibular nerves. And so just so that you know, these nerves are transmitting a lot of information. They're transmitting information about pressure, force, touch, and jaw position from various structures in your mouth. But if we like looking at the periodontal ligament, I'm not sure if everyone knows what the periodontal ligament or the PDL is, but it is that ligament that it goes around the root of every single tooth. And so when you go to the dentist and you're numbed, I mean, your ligaments are numb too. So you lose awareness of your teeth. You know, you can bite on your tongue because you probably have numbed your tongue as well. But the thing is, it's those ligaments that have, you lose proprioception, you lose an idea of pressure and alignment. And so, so basically, when you're not chewing, so when you're on a soft diet, you are losing that sensory input from the parent. You're not using your teeth for that purpose. So they're really important cues for the brain. The oral mucosa, including the palate, the tongue, and the cheek, provides tactile signals, especially with friction of food against tissues. So when the food is moving across the tissues, and the more the texture of that food, the more the tactile signals you're going to get. And of course, you have proprioceptors in your muscles of mastication and the TMJ. So the TMJ will inform the brain about the jaw position and resistance and how much chewing effort is needed. So all of this input is really dynamic and multisensory, and it basically tells the brain chewing is happening. So let's just like put it in terms of being on a modified texture diet. Like if you are on the most advanced modification of solids, like a puree diet, you're not activating many of these systems. So there's far less tooth contact, so tooth to tooth and tooth to bolus contact. There's lower muscle engagement, so less load is required, and there's reduced friction against the oral mucosa, like the bolus lubrication, the bolus wetness. So there's less friction, which is essentially mechanical stimulation. And so you have minimal jaw loading feedback to your TMJ. So this is all like explaining what is actually happening, and there is a gap in the literature linking this mechanical stimulation, like this very localized mechanical stimulation in the oral structures and the swallow reflex. And I really think it's an exciting area to delve into, because I really think that if we reduce these oral sensory inputs through loss of chewing, we would diminish the signals that normally modulate activity in the NTS and NA in the brainstem. So let's talk about external inputs that affect chewing. So, you know, we talked about those internal inputs, but now let's, you know, before food enters your mouth, our brain is starting to prepare to chew. You can call this the pre-oral phase, but you have visual cues, you have smell and context. And these are all really important in that entire eating process and activating the chewing related networks that I mentioned before in the motor cortex, the insula, and the prefrontal cortex. So when a patient sees or smells food that looks familiar or has the form of something crunchy, right? The brain automatically recruits motor plans associated with that texture. And so that's one of the remarkable things I've seen with transitional food textures like crispy melts. Even though they dissolve, and we know that they dissolve really quickly in the mouth, to the patient, you know, they have an expectation of mastication. It's a finger food, it's a solid. And so that brings that jaw movement reflexively, as if the brain is preparing for a crunchy experience. And so that anticipatory chewing could be a window. And I think it's a window into rehabilitating motor patterns through this idea of form and expectation when a patient really can't eat a regular solid. So to summarize, chewing is activated by both oral inputs like the teeth, the mucosa, the tongue, occlusion, and texture, and those external cues like the smell, sight, and expectation. So all of this kind of converges on itself to stimulate the brain, right, and support functional eating. And so if you can just envision removing some of these inputs, and we're not just losing mechanics, but we change that neural engagement that's happening. And so in this next section, I want to offer a perspective shaped by my background in prosthodontics. And I think this is really fun because I don't think that you receive a lot of lectures from prosthodontists. And I think that there's some real great things, at least in my career, I've learned so much from learning about your science. And I think that there is commonality here that is really important to share. So now we're going to look at disease and dysfunction. And so I want to look at 4 key disruptors of chewing function because we've examined chewing from the pathways sense and integrating the sensory and motor systems. But let's look now at what happens when the loop gets disrupted. Now, I want to tell you that I'm not going to talk about all the disruptors of chewing behavior. Like there's neurological, there's central factors, there's behavioral. I just don't have time to go through all of this. I'm actually really strapped for time to give you the material that I want to give you today, and I could literally spend about 6 hours talking about this. But I really want to focus on 4 things that really are in the dentist wheelhouse. And so I'm going to draw from my prosthodontics background. And so we're looking at dentures and prosthetics, right? And how that influences chewing patterns and oligodontia or multiple missing teeth to full edentalism or full loss of your teeth. Also the modified texture diet and chewing function and dry mouth. So one of the things, let me just see here. I want to share with you a patient of mine that she basically came to me with these 2 upper and lower, and there's single unit bridges. That means that all the teeth are connected with 1 unit of porcelain and gold. And so if you talk to any patient that has teeth, nobody wants dentures. Like nobody comes to me and saying, yay, I really want a set of dentures. But they're kind of forced to have dentures. And so this idea of loss, right? Like they are, you know, they're losing body parts essentially when they have dentures. And it is, it's actually considered by the World Health Organization as a disability when you're placed on dentures. But based on our conversation, you are losing that neurosensory element and mechanical loss. So just realize, like, we had to remove her teeth. I could grab that entire bridge and move it back and forth. So there was periodontal disease was pretty advanced, but just think, all of those teeth have a periodontal ligament, and we are removing, when you remove a tooth, you remove the entire periodontal ligament. And so that primary oral proprioception is gone. So that's critical sensory feedback that is going to our cranial nerve 5, our trigeminal nerve. So that is going to modulate how we chew, how much force, and precision. We lose precision. So, you know, I can show you the denture that I created. It was a lovely denture, right? But they have to relearn how to chew. So they kind of completely lose how to chew, and it takes them months to learn how to chew. And so that is like, if you can imagine someone who has dysphagia and has to learn how to chew with a new denture, that is just really hard. So there are studies that show that denture wearers get a substantial decrease in bite force. that's seen in individuals with natural teeth, right? And so this bite force is huge. Like we go from 100 down to 30. And that is, it can even go down to 10 if you get a mandibular denture. So that's incredible loss of bite force. And there's also a timing situation, right? Because their timing of their strokes, how many repetitions of strokes they need. So like you have limited, the occlusion time in mastication is changed, and your bolus control is changed. So I'm sure a lot of you have had patients where you're like, wow, they can eat anything with their dentures. But I'm going to tell you something, that's not the norm. And because they have lost proprioception, and the brain is not receiving the same input, and fine-tune movement is not possible. So basically, it's kind of a situation where a lot of adaptation has to happen with that patient. You have to look at each individual patient, whether they're capable of that adaptation. And Trolson did an interesting study where he demonstrated that periodontal afferent signals, the periodontal afferent fibers signals jaw action associated with manipulation of food. So when you lose those periodontal or those PDL fibers, it basically changes how you manipulate food. So here I'm going to talk about like what you commonly probably see is a ton of people with loose dentures, or people who just stop wearing their dentures. And you might think, wow, like this person has a loose denture and it probably needs a reline, or this denture looks really old and really worn out. But what I want you to do is take a look at the ridges, because we can see here from left to right, we have minimal resorption of the alveolar bone here. And then you're starting to see more resorption patterns here, where you see like this thinning right here at the very top, the ridge. You see this thinning right here in the maxilla. And then here you can see this widening in the tuberosity region, and I can probably estimate that this tissue here is loose and flabby in the maxilla, and here that ridge is almost non-existent. So when you think about the denture sitting on these ridges, as this patient is changing, those dentures are getting bigger and bigger because they're replacing missing soft tissue. So there's basically the patient. If we kind of go back to the patient, we see the patient having to constantly adjust their dentures based on the food that's in their mouth, and their tongue is working overtime. So like the more bone that's lost, the tongue and the and basically the muscles of mastication, so they're used more to stabilize his denture because the bone isn't doing the job. Okay, so if you can just imagine someone who's had a stroke who has lost that sensation in their tongue, or they have some palsy, then you basically have flipped the switch on them being able to use their denture effectively and to control the bolus breakdown. I think that the other thing I want to mention here is that worn teeth. When you're looking at that denture, you're check to see about retention stability. Like, is this thing rocking back and forth when you put your alternating finger pressure on it in the posterior molar region? And then also look at the wear, because if those molar teeth are completely mowed down, they're completely worn, then you're not going to get the right kind of bolus manipulation and bolus preparation. They have to do more of a vertical chew pattern and then a sweep away, because the teeth are not there to help create those sluice ways for the food. So I want to share with you something else. People always talk about these loose dentures, and the impact of loose dentures on bolus control and bolus manipulation. And boy, my patient's better off not wearing their denture, that kind of thing. I'm going to get to that part, but before I do, I want to talk about the overbuilt denture, because you're going to see this more and more often. You're going to see dentures that have been built up, you know, like they are big. And the reason is because implant dentistry is like huge in the US, and this idea of implant supported dentures, and then also fixed implant supported prostheses, which are called hybrids. And so these require more room to construct. And oftentimes dentists don't realize how much room is needed. And so when they make the dentures, they're like, oh boy, we need more room to cover all this metal work underneath, and these dentures get big. And so what happens there is it violates one important criteria, which is really important to you. And that's, it violates this idea of freeway space. And so freeway space is the space between our teeth when, you know, when we are talking. It's the space when we swallow, when we end the swallow, our jaws separate a little bit and we have a little bit of space. But if your denture is built up to the point where there is no space, you are going to get patients that complain of a few things. They're going to say, I don't have room to take a bite of my burger. My jaw hurts. You can have extreme amounts of TMJ pain, or I can't swallow. And I can't use my tongue anymore to clear my food. So they can't actually take their tongue over their denture and into the sulcus and clear out residue. So, you know, they've done studies to show that when this increase in vertical dimension, is what we call it, happens, it can interfere with phonation and mastication and swallowing. So, you know, when we think about dentures, we often focus on how well they chew or how often they fall out, you know, but what if I told you that even just wearing them, even for a puree meal, makes a difference? So I'm going to put a caveat here, like I'm talking about a well-fitted denture that doesn't cause pain, you know, because if there's pain involved, then that changes everything. And let me also say that you should have your dentist as your partner. There should be a good relationship there to help you make these decisions. But if you were to ask me, and this happens a lot, well, you know, we did this modified barium study and they weren't wearing their dentures, or we like it to be how they are normally, they don't use their dentures. But let me just walk through why it's important for them to wear their dentures. When dentures are in place, they are restoring the contact surfaces. So it's back to that vertical positioning of the jaws. And it gives the tongue something to press against and the brain something to respond to. So without them, patients are losing the critical sensory cues. I mean, you've already lost the sensory cues from your periodontal ligament, and this denture, this external, I guess this acrylic that's contacting tissue, there are mechanoreceptors in our tissues as well, and so it provides you with oral awareness, right? And so without that sensory cue, that oral awareness drops, and the system has to guess where the bolus is in your mouth. And so we have data showing that wearing dentures reduces molecular residue too. We have studies showing that it shortens oral and pharyngeal transit times and improves confidence in the act of swallowing itself. And in one study, simply wearing the denture resulted in more effective bolus preparation. Another study showed that palatal contouring, if you did effective contouring of the upper denture, the palatal aspect of the upper denture, it enhanced swallowing by better engaging with the tongue. So think of the denture not just as a chewing tool, but as a neurosensory scaffold. And it can really help you for better swallowing, even when on a puree diet. So, you know, if your patient asks, should I wear my dentures at meals, even on soft diets, I would say yes, they should. So here, I'm going to share with you a modified barium swallow study done by Brian Hedman, who's at Cleveland Clinic. And he shared this with me, and I would like to show, like, look at the jaw patterns. So you can see here jaw elevation with tongue propulsion on the puree, but this is a transport behavior, so it's not masticatory. And I wish I had AP views for you, but if you look, this is a transitional food. This is a crispy melt. Now look at the chewing patterns. You see some that are organized strokes and then some that are shortened strokes. But you can see that this is activating. Now, the other thing I want you to notice is this person has no maxillary denture. So you have mandibular teeth and no maxilla. So that mandible has to auto rotate all the way up to touch that maxillary tissue. So that's really important. Now you can see them with a graham cracker with barium pudding. Now, what's interesting here for you to note as well is that they are anteriorizing the food. It's staying up here. Where is the bone the highest, or I could say the lowest, in the maxilla? It's right here. I can almost guarantee they have more residual ridge up here, so they are an anterior chewer. I mean, what's the point in chewing in the back here? They have a larger vertical space. They're not using their denture, so they're chewing more anteriorly, and it's highly inefficient. So, you know, if you can get someone to chew in their molars, you're going to gain a lot more efficiency. And you can see here how many strokes this person needs to take in order to break down that food. And so these masticatory strokes can be counted, but you can obviously see that fatigue is going to happen as they're trying to manipulate this harder texture. So I want to share also about dental implants. Of course, they're there. They're our panacea. They help people, you know, who are missing one tooth, two teeth, all their teeth. It's great. I was an implant specialist for many years and did a lot of research in implant dentistry for a long time. And so what I want to share with you is this idea that you're going to see patients with implants in their mouth. If you turn the lens on what's happening here, these are dentures that stay in the mouth. They don't come out. They're fixed to these implants down there. And this patient has to clean underneath with floss threaders to clean out all the residue. Now, when in dentistry, we are not taught about dysphagia. You know, Japan, yes, they are taught, especially in oral maxillofacial surgery, but in the US and Canada, it is not part of our curriculum. We get a glimpse of it, but we don't really get educated on it properly. And so what I would like to say is, because of that, dentists are not thinking 10, 20 years down the road, or when there's more medical compromise and this person has an inability, they have dysphagia. And now residue becomes a bigger issue, right? It becomes a risk factor that is significant that can lead to aspiration pneumonia. So I want to share with you that hygiene risk here, because it's harder to clean. You're not going to get a CNA to go in there and remove this, and the CNA is going to have a tough time cleaning underneath this as well. So I just want to mention that, but also say that bite force is incredibly harder. You're back up to having the bite force of natural dentition, even higher than natural dentition. They can crash through anything, but guess what? They don't have a periodontal ligament. They can't feel it. I've had patients almost bite off my finger. So like, you can overchew, you don't feel food the same way. And so you're getting different type of stimulation to the brainstem. So keep that in mind. And then oligodontia, which is multiple missing teeth, you're reducing molar contact. The number one tooth to be lost in the mouth is the second molar. Well, of course, the wisdom tooth is highest, but the second molar as far as a true chewer. And so that's the most potent chewing region. And the more anterior you get, so you're getting only anterior teeth, the less functional you are and the less effective you're going to be in creating that bolus, even with soft solids. So, you know, texture is a message. So what happens when the mouth goes quiet and you're on a puree diet? So when patients are placed on a puree diet, one of the most significant changes is the near elimination of the chewing process. Okay, without the need to grind or manipulate food, we lose not only the mechanical stimulation of the oral cavity, but also the proprioceptive feedback that chewing provides. And this really matters, as we saw in the brainstem with, you know, the influence of chewing, modulation on swallowing. So what is the result? We often see poor bolus control, delayed oral transit, and an increased likelihood of molecular residue, especially in older adults. And so this is, you know, this is really important. I'm going to share with you a research study which kind of looks at this idea of like, how can we have, you know, how can we look at chewing patterns and puree diets versus transitional foods? So keep in mind this link between the puree diets and the oral phase dynamics. You're going to eliminate the need for mastication, right? You're not using those muscles. You're not getting the sensory feedback. You're reducing that tongue palate pressure demand. And you're changing you're impairing that bolus cohesion risk. So this is something to consider. The changes in chewing, I mean, it's intuitive. You're going to change chewing when you are on a puree diet, but what are the ramifications? And then finally, I want to talk about saliva. So here, you know, we could spend an entire hour talking about saliva, but it has many different influences and properties that affect our ability to have bolus manipulation, bolus lubrication, but also cleansing of our teeth, cleansing of our tissues, and also the digestive enzymes, so helping with our overall digestion. So what happens when we reduce saliva? So it's going to affect your dentures. Your denture retention is going to be much lower, and you're probably going to need to use denture adhesives. Your chewing is going to change because chewing is oftentimes influenced by saliva, a saliva pellicle on the teeth. The speech is altered when you have a xerostomia or dry mouth. Your taste sensation changes. Saliva interacts actually with the food, but it also interacts with your taste buds. And you have increased likelihood of residue. The quality of the residue changes, the stickiness of the residue, if you will, and the quantity of it. And finally, like that lubrication of the bolus, the potential for lubrication. Now on the bottom here, we're seeing here some of the disease associated with reduction of saliva. You can have atrophic candidiasis. You can see that here on the right hand side. Angular cheilitis right here. You have decay showing here, and it also influences your risk for periodontal disease. So keep this in mind, and please be careful of patients with dry mouth and giving them high sugar content, because they're going to have an accelerated loss of their teeth because of the neutralizing or the effect of saliva from a mechanical but also from a chemical standpoint. So, you know, this is just an overall slide of residue and risk. So everything that I mentioned has an influence on residue. So you are with your dentures, you're dampening your mechanoreceptor input that I mentioned before. You are changing your mastication reflex, and so that residue is influenced. Your oligodontia, you have inadequate occlusal contact, you are affecting your bolus formation, you're affecting this bolus cohesion, this ability to form that bolus, and your reliance on the tongue to help you with that bolus. Your advanced modified texture diets, you're reducing the need for mastication, which is fine, but you're actually affecting that chewing. The reduction of chewing means reduction of stimulation in that cortical network that I shared with you earlier. And studies are showing increased follicular or oral cavity residue. And dry mouth, you're losing lubrication, poor bolus cohesion, and increased effort for that oral transport and early fatigue. You get that sticky bolus, oral residue changes, and pharyngeal stasis. So of the bolus. So then what I want to talk about next is this idea of functional textures. So this is a really novel idea, and I'm excited to share it with you because historically we often talk about modifying your texture for safety, but what if texture could also support functional gains? So I want to introduce this concept to you today of functional textures of foods. And these are foods that not only minimize risk because they're supporting early chewing, stimulating sensory input, and also providing meaningful improvements in that swallowing readiness. So I want to delve deeper into this concept with you. And so, so if we talk about functional texture, we're talking about a category of foods that do more than passively meet safety standards. They're actively contributing to rehabilitation. These are textures that intentionally engage the oral phase of swallowing rather than bypassing it. So like what we want from a functional texture is to stimulate sensory receptors in the mouth through pressure, friction, and taste. And it must do all of this and at the same time dissolve predictably in the mouth to avoid risk. And you know, this idea of this this behavior of food, this functional behavior food, comes from this body of knowledge called oral tribology. And this is in food science. And tribology is the study of friction, lubrication, and texture perception during oral manipulation. And so it gives us a framework for designing foods that have this functional texture to mimic certain aspects of mastication. So unlike purees, which have low friction and minimal resistance, functional textures introduce controlled mechanical engagement that help maintain oral motor activity and we hope stimulate neurosensory pathways. So this is a patient of mine with dysphagia secondary to squamous cell carcinoma in the oropharynx. And she is the reason why I'm here with you today, because she started me on this journey. She trusted me with her oral full mouth reconstruction, and really, you know, almost every visit she would cry, right? She had so much fear and worry about her future, grief over the loss of her teeth and tissues and her confidence and her loss of saliva, her continued modified diet, her dysphagia. And so in our getting to know each other, she would recount stories to me about her experience during her cancer treatment phase. And she told me she could handle almost anything, but her desires were really focused on texture. And I just want to share this with you.
But I tried the oral or the shakes and different things like that that were on the market. I wanted something that I could bite, something I could, that was like real food. but I tried the oral or the
So, so that is like really describing this impact that we have with texture. And I'm, when the mouth leads the mind. So it's really not just about oral mechanics here. It's about like identity. The small act of, if we can give them a functional texture to break that narrative, to shift from I have to eat to I want to eat. We can see a spark, like we can see motivation and emotion and even joy. And I've seen it over and over again. And in that moment, therapy it becomes personal. And that's why reintroducing these textures matter. And it's where this concept of functional texture that fits into recommendations can help. So, what we know is that these functional textures, if they are re-engaging that early chewing pattern and activating that prefrontal cortex, that's how we're going to elicit that emotional reward. So I'm really excited about this emotional shift, which was like honestly the genesis of why I became an entrepreneur. So we can look at what do we want from functional, like what would be the golden, desire from a functional texture for dysphagia management. So you want it to be able to be used at the early stages, when that patient is feeling the most deficit from texture restriction, so at the puree stage. So the other thing is like if it can be a finger food, as you can see with this gentleman, they can re-engage in that bite, that initial bite, the lip contact, and also just picking it up with your fingers, so the pre-oral phase and the anticipation. So the other thing is, of course, that texture, that tribology conversation that I had, it needs to dissolve. It needs to meet tissues and be able to dissolve predictably and reduce residue and scattering of the bolus. So you don't want it to particulate. You want that to match the friction and the dissolution and the saliva properties of that individual to facilitate that safety in these early texture trials. You want to stimulate multiple sensory pathways. Just by having a solid, you're going to stimulate these gustatory, it's nutritive, you're getting olfactory, and this is more into the sensory side of things, but we are getting multiple sensory stimuli outside of just chewing alone. So we want it to contribute to protein and energy intake. We don't want it to be empty calories. We want it to be a nutritive tool, but also mindful of what kind of nutrients that person needs. It also should have versatility across settings. So can we use it at mealtime, therapy time, at home? And so some people say, well, aren't transitional foods functional textures? And you could say that some transitional foods fit into the definition of functional texture. But if we read the definition of what a transitional food is in the IDSE framework, which I'm sure most of you are aware of, it's foods that start as one texture but change into another with moisture or temperature change. Now, because of this description, it's not just in the solid foods that are more descriptive in a functional texture. It can include things like ice. It can include magic cup ice creams because they are changing texture with temperature. So we're talking more of these solid foams. So, and the genesis of this transitional food, it was because of the importance of meltables in pediatric feeding therapy. Like transitional foods wasn't used in adult therapy that often. And I heard from SLPs that they were tired of giving their patients baby food, like these baby meltables. And so the other thing about functional textures and IDSE is like IDSE's role is to provide standardization and specificity to these categories to reduce risks in preparation and identifying foods appropriate for an individual. What I would say is that transitional food as a category is massive, and there's so much variation in the oral behavior and endpoint texture prior to swallow. So you really need to know, what this transitional food, how it behaves in that particular individual before using it. And I would say that you would have to classify transitional food. Is it appropriate for puree? Is it appropriate for mince moist? So you really need to get to know these transitional foods. And oftentimes they're just they're store-bought products that aren't geared towards IDSI. So unfortunately, you have to do a lot of that work to figure it out. So these transitional textures, IDSI doesn't really talk about using them for the rebuilding those oral phase skills. And so that's where I'm hopefully going to shed some light on how this can be useful for you. So let's look a little bit more at transitional foods here. The frequency of passing the fork pressure test, you can see that there is tremendous amount of behavior differences. Some are called transitional foods, but 8 out of 10 times they are passing. So sometimes they're not even passing the fork pressure test. So trying that fork pressure test multiple times is really important, but knowing what that endpoint texture looks like. Does it look more like puree or is it particulating? In this study here, what we did was we looked at graham crackers. So this is Valentina Marchetti. She studied at Weill Cornell in an outpatient clinic. Her dysphagia, a heterogeneous population, patients with dysphagia using fees. And they were looking at these 3 textures. It was applesauce, it was a crispy melts, and it was a graham cracker. So what they did was they had blind raters evaluate the fees, and they used VASIS. So to look at the visual analog analysis of the residue, the amount of residue that was left in the oropharynx, hypopharynx, and epiglottic spaces. So what was interesting here was there was 219 swallow trials, and what they saw here at the bottom is the frequency and number of swallows by food texture. The left here is the transitional texture. This is the puree, the applesauce, and this is the regular or the cracker. And what they saw was a greater number of swallows was needed for the puree. So this is 1 swallow needed, 2, 3, 4, etc. And there was greater, this is the residue in, if you're looking at the oropharynx, the hypopharynx, and the epiglottis, they found there were statistically significant differences in amounts of residue. So they found there was more residue with the puree than there was with the transitional food, and there was more residue with the regular food than there was with the transitional food in the epiglottic and oropharyngeal spaces. All 78 transitional food trials had a PAS of 1, but they couldn't do more than descriptive statistics on this because they didn't have enough differentiated data. And so they concluded that medically tailored transitional foods may be added to evaluations and to a puree diet. And in this study here, they went further to look at a video fluoroscopic analysis of transitional foods. And they looked in an LTAC setting at 29 patients and mean age of 56.8, and with underlying conditions of COVID, neuro, and other. And so they all had this MBS-IMP criteria used, and they coded the transitional food with Veribar, and they used it in their setup for their modified barium swallow. And so what they noticed here, and they evaluated 14 components of the MBS-IMP. and overall oral total composite scores and pharyngeal total composite scores. So what was interesting was there was no statistical significant difference between the transitional food and the puree. So really, it was interesting here. You know, we don't have enough time to go into it, but just how mastication is evaluated in this component score. And what we're talking about here, like with chewing, it's kind of a different lens. And so in this study, the transition of food did not increase apparent risk, right? So they said that there was clinical utility in using transitional foods in evaluation protocols. Finally, I just want to share with you a framework for how can we use functional textures. So it's a sensory triggered intake and recovery. And really what it is an evolving clinician guided practice using functional textures to stimulate that oral function and improve that readiness and hopefully advance texture recommendations over time. So I think that, you know, really the rationale is to stimulate that oral and pre-oral sensory pathways and facilitate that bolus formation and cohesive transport early in the game. So using a texture that's dissolving so that you can get that early mastication movement happening and hopefully change that motivation level for the patient, that emotional part of the equation. And lead the patient to be able to pick up something with their fingers and take it to their mouth and do that independently over time. So that's a purpose. Now, when we look at what kind of patients would do well with the STIR protocol, it would be patients with oral, pharyngeal, or mixed dysphagia, and you have a goal of texture advancement. They need to be able to follow basic instructions and minimal aspiration risk. They can have fatigue or withdrawal, and you're trying to use this food as a textural stimulation. And they're on an early modified diet, ideally puree or minced and moist. And you would have to select your functional texture based on the patient's diet level and dissolvability. So what's really important here is being able to glean what is a good masticatory stroke and knowing that stroke patterns change when you have dentures. The beautiful stroke is one that has this lateral shift. So it's not just vertical up down, but there's an elliptical jaw movement and it's rhythmic and purposeful. And there's intermittent lip closure and buccinator activation. And you want to see an effect. So you want to see that bolus movement or tongue lateral movement to consolidate. So here you can see here this kind of with the barium and pudding alone, you're not seeing true jaw movement. That's just up, down, but it's non-functional. And then now when you're going to use a functional texture, keep in mind this person has no lower denture. They have an upper denture in place, but you're seeing more of a, like it's more vertical, and that's why, you know, you really need an AP view to see this properly, but you're getting more of a chew response, and that's what you're goal setting with this functional texture. So what you want to measure is the number of chew strokes, very similar to the TOMAS. You're looking at chew to swallow time, cue dependence, bolus cohesion, and sensory reaction. Are they positively responding to this, or is it negative? And how, are they reaching for food and timing the timing of their bites? So you would want to start the STIR with just using it in assessment. So you use a functional texture, take 2 to 3 bite-sized pieces per session, and you're evaluating the bolus formation, fatigue, chew coordination, and readiness. If there's positive effect, then they can be carried forth to doing this structured between session practice of 3 to 6 bite-sized pieces, 3 times a day to build consistency, reduce fatigue, and support function. And if you're getting a positive response there and minimal fatigue and residue, then you can step up to 6+ pieces 3 times a day, building efficiency, engagement, improve progress markers. Now, this does not take away from you doing your assessments for texture upgrades, but this is a way to facilitate this like masticatory re-engagement. So I think that we're running out of time here. So I would like to just kind of move on ahead. This is a great study showing early therapy use in this idea of in therapy session and use outside of therapy as an exercise, an oral exercise with functional textures, and showing that they were able to really advance the IDSI level progress by now this is an early pilot data, but it's really helpful to see that there is a benefit in the E10 scores and also in the IDSI level by using a functional texture. So I just wanted to end this presentation by saying this was a lot of content. I have here a QR code, and if you want to just take a screenshot of that, or you can go to the link and just tell me what you would like. If you would like more information, I also am offering some samples of functional textures for people, and you know, I was going to give away some, so be early in that request if you're interested. But really, if you want information, handouts, resources, research, just use that QR code and tell me what you want, and I'm happy to help. Thank you.
Excellent. Dr. Barewal, thank you so much for this presentation. I think I probably speak for many people who joined us tonight. You just don't know what you don't know, and I learned so much that I didn't learn in school, and so much that is applicable to clinical practice here. I want to get to a few questions, if that's okay.
Yes,
We
sure.
have one here from a person who's on a modified diet. They're eating an IDSI level 3 to 4, and it seems that the thinner the food bolus is, the less filling it feels in the stomach, noting that the texture that helped make them feel the fullest was a thicker texture.
Yeah, I think that honestly, that's a perfect example. I wish we had more literature on this, but essentially the idea of texture, tribology, that those mechanoreceptors in the mouth, the sensory receptors in the mouth, and how that friction, even if it is not a regular solid, but you're gaining more sensory feedback. And if you are using, you know, mixed consistency, let's say, or, you know, soft and bite-sized, and you're eliciting some chewing, I think that can actually help with that satiety signaling.
Excellent, thank you. When you were speaking about how dentures, people that receive dentures, it takes them weeks to months to figure out how to chew effectively again. Do you follow any sort of specialized protocol, or is there a standardized approach for teaching patients how to chew safely and effectively again?
Oh, it's a person-to-person experience, and there are practices that you do share with patients. I really want to also tell you that residue resides underneath the denture. And as you're learning, that residue can be painful, and also it can pack in there. So just, you know, with respect to dysphagia, you know, we could have an entire lecture on residue from the oral cavity and prosthetics. But what I want to share with you is that what we're teaching is bilateral chewing. That's the basis of it. If you have a complete denture, you can't chew unilaterally at first. You do, 80% of us do favor one side with natural teeth, and it's a huge shift for someone to get all their teeth removed and then to figure out how do you chew on both sides. In fact, tonight, try chewing your food on both sides at the same time. Mm-hmm. It's really hard. And so that learning that has to happen to balance the denture so it doesn't flip up when you're chewing is a true, like, that's the first win. But yeah, there's more to it than that.
Excellent, thank you. How often should somebody be getting checked to see if their dentures are still fitting?
Yeah, so I have annual visits with my denture patients. And so that is really important because you want to catch things early. If you don't catch it early, and this is the other thing, general dentists are not getting trained as much on dentures as they used to. And that's just the advent of CAD-CAMing and aesthetic dentistry, etc. So it's just a curriculum concern. So, you know, I practice in a way where, you know, a lot of my patients had dentures. And so I would see them annually. And the reason for it is that you want to catch relines early. If someone needs a reline, especially with implants, because you could damage your implants, but you catch it early. Number one, it's going to stabilize the denture. Number two, you're going to reduce resorption of your bone by irritation by an ill-fitting denture. And the other thing is you want to check the teeth. You want to see that they're not worn down. Because like I said, you're concerned as an SLP about bolus manipulation. Well, if these dentures are no longer doing the job that they used to do, you're running the risk of bigger boluses of food, undigested, unchewed, getting swallowed.
Excellent, thank you. I'm going to ask one more here and then be mindful of your time and our participants' time here. If somebody's on a pureed diet because of their dysphagia, would you consider recommending having them remove their dentures just to improve sensation that can be gained from the hard palate?
No, I would recommend keeping that denture in place. One of the things that there's pros and cons, right? Like you're getting some taste sensation from your palate. But if you have a denture and you have the volume of space taken up by the acrylic appropriately, you're creating the house for the tongue. And so it's controlling, it's helping the tongue understand how to work within a dimension. It's like being lost in a big space versus having more of a confined space to work out of. It offers more control. And so, you know, we can even see that with a lower denture. And in fact, when patients of mine have not worn dentures for a long time, I see a change in their tongue shape. And it gets bigger. It's spreading over the residual ridge. And that doesn't make it a better or a smarter tongue. It makes it, you know, like it's almost invasive. And so I have to fight back that tongue in creating a denture that works where you're getting proper chewing vertical, you're getting proper contact. So puree, I think having the denture in place, creating that house for the tongue, is important, and I would hazard a guess that you would do a modified barium swallow and you would see differences when the person is wearing the denture versus when they're not.
Excellent. Thank you. I think I'll pause there on questions. There are more that came in. If we didn't get a chance to answer your question, please feel free to email us. I'll be sending you an email right after this within the hour that will have our email address, and I will also include Dr. Barewal's contact information if you would like to reach out directly. Several people have asked about the slides. I will direct you to this QR code that's on the screen here where you can request what you are interested in. If there are portions of this presentation that you would like to review or get more information on, you're welcome to contact Dr. Barewal. We will also have the recording available on our website within the next 24 to 48 hours. The email I send out will have a link for the survey. So again, if you're interested in ASHA CEUs, please fill that out by the 15th. If you're not looking for CEUs but would like a certificate of participation, you can still fill out that form and we'll email you a certificate. And with that, I would like to thank you, Dr. Barewal, for your time and your expertise tonight. Thank you to all of you who joined us. We had just under 1,000 people register for this event, so a highly interesting topic. Again, thank you. Have a great evening, and we hope to see you again soon. Take care.